Just got it up.
Thank you. Well, welcome. Good morning. We thank you for joining us this morning. Today, we're going to discuss the Justice Involved Juvenile Coverage Implementation, which is a CMS requirement for states to implement. And then we're going to discuss a grant we received from CMS to help support the implementation of these new benefits. So this is the December 3rd webinar. This is our first of two. We go to the next slide. Today, we're going to discuss the Consolidated Appropriations Act. We're going to do an overview. We're going to talk about the grant we received from CMS and what we are doing with the grant. And then we're going to talk about the coverage that we are required to implement. We're going to talk about a state plan amendment that we need to make to ensure we can provide the coverage. We're going to talk about an implementation timeline, the phased approach that we're taking to implementing this coverage. We'll talk about state legislation that was passed in 2025 legislative session to support this work. We'll go over eligibility and Medicaid suspension, and then we'll talk about some provider credentialing. And then Department of Corrections will do an update on where they are in this implementation process. We'll go over the limited benefit package that these youth will receive 30 days before they're discharged and then 30 days after. And then we will talk about the questions we received and we'll answer those. There'll be some that weren't pertinent to this discussion that we will respond to directly, but we'll discuss all the questions that are pertinent. And then we'll go over next steps. My name is Larisha Ratliff, and I'm the Director of Government Affairs for Indiana Medicaid, and I'm also the project lead. And so I will kick us off today.
Larisha, I'm sorry to interrupt. We have a few people in the chat saying they can't see the slides.
Okay, so
we could take down the slides and then put them back up again and see if that helps.
Yeah, let's do that. Sorry about that. It might have just been that individual because I think we're getting a lot of responses in the chat.
Yeah, we got some can see it and some can't.
Okay, so most can see, so we'll go ahead and continue. So we went through what we're going to discuss today, and we'll go on to the next slide. And I think it will also be helpful if we mute the chat. So Brittany, see if you can mute the chat for me.
I will.
So, a little background, the Consolidated Appropriations Act of 2023 included two provisions that were applicable to Medicaid and CHIP surrounding children and youth in carceral settings that went into effect in January of 25 and outlined below. The mandatory part is the screening and targeted case management, Section 5121. And that statute requires that Medicaid and CHIP cover certain screenings and diagnostic services in accordance with EPSDT requirements 30 days prior to release or within 1 week or as soon as practicable after release to eligible juveniles who are post-adjudication in public institution. It also requires Medicaid to cover targeted case management, which is TCM, 30 days prior to release and for at least 30 days following release. We are not doing the optional section of 5122, so I will not discuss that today. We are implementing what is mandatory and what is here in the green. Next slide, please. So FSSA was awarded the Consolidated Appropriations Act Planning Grant in August of 2025. That grant is to support procedures and build infrastructure for data sharing related to continuity of care of healthcare provided to the state's youth population involved with the justice system through the age of 21 and those who were previously in foster care system through the age of 26. The grant funding cannot be used to pay for any services related to the requirements of Section 5121. So we cannot use the grant to pay for any EPSDT screenings or the targeted case management, but it can be used to support implementation requirements, address any operational barriers for sharing data, promoting continuity of care, and making system improvements for ease of sharing of data. FSSA is targeting a state plan amendment. As I noted, we need to make some changes to our state plan to provide these additional services with the effective date of January 1st, 2026 to provide fee-for-service diagnostic screening based on the EPSDT standards and targeted case management for an individual who had suspended Medicaid while residing in a facility, inclusive of coverage that is 30 days before and 30 days after that facility stay. So for the grant, we were awarded a grant from CMS. We are not, FSSA is not awarding grants out. We received a grant from CMS. It is a 4-year award that we will get in 1-year increment, in 1-year periods that are non-compete. So we will provide CMS with an update on our progress, and then we could get the grant year extended. So we were awarded $4.2 million over the 4 years. This first grant year, we have $1.3 million for the year 1 budget. What we propose to do with the funding is we propose to create a survey. We're working with IU School of Medicine through their WISE research area to create a stakeholder survey, including agencies that are providing TCM and other information that will help us as we implement this benefit. So we budgeted about $150,000 for that. System enhancements, we budgeted about $500,000 for that. That will include cost to core, possible IEDs, Cognos dashboards, and that we also are working on some Tableau dashboards that we will use in that system enhancement pool. We also budgeted $75,000 for training. That will include staff, internal, external, any travel we may need to do. We budgeted for that. That's $15,730. We plan on going to facilities. We've visited the I was trying to think, it was the Pendleton. I was going to say Plainfield, the Pendleton facility. So thank you for that, Nanas. And we plan on visiting other facilities as we implement this coverage and benefit. We also have about $530,000 budgeted for staffing and project management, and then around $50,000 budgeted for indirect costs. And again, this was a 4-year grant award that is non-compete for the additional years, and the overall grant that we received is $4.2 million. So do apologize for any confusion. There is not a grant that providers can get or anything like that, but the grant is to help us as we implement these services. Next slide, please. So the stated plan amendment, the SPA timeline, public comment period is happening now. That went in effect November the 26th. It will go through December 26th. We will aim to submit the SPA to CMS December 31st of 2025 with an effective date of January 1st of 2026. So next slide, please. I'm going to discuss our implementation timeline, and it'll make more sense once I do this. So in the phase 1, which we're in now, we are working with Department of Corrections for the initial rollout. So we are working with Department of Corrections to build clear process procedures, handoffs, how things will work so that we have detailed information to provide to other facilities, the data exchanges, what things need to happen and how they happen. We have an interagency governance committee that we meet bi-weekly. We have an internal Medicaid work group too, where we meet internally just within our own agency to work with the different sections on the things that we need to do to make sure we implement this coverage statewide. We hired a reentry coordinator that joined us on Monday, and so we're excited about that. We're, like I said, working with WISE on surveys so that we can get evaluation and feedback. We are working on system updates to not really change the Medicaid suspension process, but just to ensure that we can ingest those files and get the data that we need in the Medicaid office. We are developing protocols for data sharing and templates for MOUs that we will use to roll out to the other facilities. And again, we are focusing right now in phase 1 with Department of Correction in their 3 facilities. And then we will use the information from the survey to conduct a descriptive analysis and to help understand gaps, barriers, and anything that will create an issue with the providing these services, especially post-discharge or post-release. We want to make sure that the 30 days of targeted case management can be accessed. In phase 2, we're going to move to the statewide rollout to all juvenile facilities. We're going to target beginning that mid-year, so July of 2026. And we will begin to work with other facilities to ensure that they can submit their data files and that we can ingest those files and produce the proper follow-up information to them. We are going to complete statewide training just to make sure the provider credentialing and all of that stuff works and everybody understands how to submit for the limited benefit. We'll talk through that, like I said, a little later in the presentation. And then we will monitor performance and outcomes and just ensure that, again, the 30 days before there's access happening and then the 30 days after that TCM is still being able to be accessed once that juvenile leaves the facility. We will continue to meet bi-weekly to just pay attention to what's going on and the monitoring. And then we will move into phase 3, and that is to begin to review the outcomes and impacts of our implementation. And really around year 2027, we want to make recommendations for if an 1115 will be beneficial to our state and just understand would it make sense for us to waive and to work out in 1115 if we were to go that route. So we'll move on to the next slide. I'm going to pass this over to Nina Spinner, and she will discuss this slide with you.
Thanks, Larisha. Good morning, everyone. Thanks for joining. I'm Nina Spinner, and I'm the Director of Eligibility for Indiana Medicaid. I did want to let you know that the chat was a little bit distracting, so we've turned that off, but we do have at the top, you can see a Q&A function. So if you have questions that you want to put in there, we will try to address as many of those as we can after the presentation. It may be helpful if you put your email address in your question, just in case we need to follow up afterwards if it's not something we can answer now. But we'll go ahead through the related state legislation. So Senate Enrolled Act 486 was a bill that requires a sheriff to assist an individual who's been incarcerated for at least 30 days in a county jail, community-based correctional facility for children, juvenile detention facility, or secure facility other than a child-caring institution, and is eligible for Medicaid. The sheriff is to assist the individual in applying for Medicaid before they're released from the facility. It also provides that if a child loses Medicaid coverage while confined in a juvenile detention facility or secure facility, the Division of Family Resources, or DFR, will, upon receiving notice that the child will be released, take action necessary to ensure the child is eligible to receive specified federally mandated services for 30 days before and after the child's release. So this new benefit that Larisha was discussing. Next slide, please. So the eligibility that works here, we have had suspension for incarcerated individuals for a very long time. There have been some little minor updates to it here and there, but this part is not really changing. So federal regulations prohibit Medicaid from covering healthcare for individuals who are incarcerated. Indiana Medicaid members who are incarcerated for at least 30 days have their Medicaid coverage suspended. That means they're still in our system and we have all the information on them, but no claims can be submitted to Medicaid during the incarceration period. The one exception is for inpatient hospitalization, where for the Department of Corrections and county facilities which have an agreement with Medicaid, it's not all of them, there is a specific contract that we enter with them. Medicaid can cover costs for the inpatient stay even if coverage has been suspended. Incarcerated individuals can also apply for Medicaid prior to their release. So if they didn't have Medicaid when they became incarcerated, they can still apply. All of the normal eligibility factors, including income for their household members, must be verified, and they must be found eligible for Medicaid. But if they're approved, they'll be opened directly into that suspended status in preparation for when they're released and they could be reinstated. Once an incarcerated suspended Medicaid member has been released and Indiana Medicaid, really the Department of Division of Family Resources or DFR is notified, their coverage should be reinstated within a few days. Next slide, please. So who is eligible for this limited benefit package? Eligible juveniles that were enrolled in Medicaid before becoming an inmate of a public institution, or those who are enrolled while an inmate of a public institution. They need to be Indiana residents with a qualified citizenship status, which would allow them to receive full coverage Medicaid. A Medicaid eligible individual who is under 21 years of age with suspended Medicaid, or an individual between the ages of 18 and 26 who is eligible for Medicaid under the mandatory former foster care children group. This is a group for individuals who age out of foster care at 18. They are eligible for coverage that lasts until they turn 26. These requirements apply post-adjudication, meaning a court concluded the child or youth committed the act for which they were charged, and the current estimated population is about 415 individuals per year that will be eligible. Where do the requirements apply? It would be correctional institution is considered a public institution and may include state or federal prisons, local jails, detention facilities, or other penal settings such as boot camps or wilderness camps. Adult facilities may be included in these requirements if an eligible child or youth is involved in the adult system. Next slide, please. An overview of how the suspension process works. DFR, again, the Division of Family Resources, those are the offices where someone can go and apply for SNAP or TANF or Medicaid. They will receive a data file of incarcerated juveniles from the facility and determine whether or not the individual is already on Medicaid. If the individual is a current Medicaid member, then DFR will suspend their coverage. If they are not a current Medicaid member, DFR will return data to the facility indicating that a Medicaid application is required. For those whose ongoing Medicaid was suspended, or those who are approved into a suspended status during their incarceration, DFR will reinstate their full benefits no sooner than their actual release date once they're notified by either the facility through this data exchange or the member themselves. A couple of best practices here. Facilities should assist in submitting a full Medicaid application as soon as possible, preferably at least 60 days prior to the release, so the juvenile has that suspended coverage in place in time to receive the limited benefit 30 days prior to release. Another best practice, the release should be reported to DFR in a timely manner. If there's a delay and the release is not reported in the month in which it occurs, full coverage will resume the first of the month in which the release is reported. So if they were released a few months ago, but we just learned about it now, the full coverage will start this month going forward. Next slide, please. Opening the limited benefit. So for suspended members, 30 days prior to the release, the facility will be able to use the provider portal, that's the Indiana Health Coverage Program's IHCP provider portal, to complete the application for the limited benefit and receive a determination. If the individual does not meet the eligibility criteria or does not currently have suspended Medicaid, the limited benefit package cannot be approved. If the outcome of this application is an approval, the limited benefit package will be open and visible for providers in the provider portal immediately. The effective dates of the limited benefit will be 30 days prior to the release until 30 days post-release. And I think the next slide I will pass to Michael.
Thanks, Nanis. Good morning, everyone. My name is Michael Cook. I'm the Director of Provider Services with Indiana Medicaid. And I'm here to give a brief overview about how our correctional facilities will actually be accessing this benefit through provider enrollment. So in order to receive reimbursement for these services that we've discussed today through the Consolidated Appropriations Act, we are going to require that correctional facilities enroll with the Indiana Health Coverage Programs as a provider. And we're trying to keep this as simple as possible. We know that going through the enrollment process can be a little complicated for providers. So we have streamlined this application as much as possible. And we've really narrowed it down to 3 key things that you need to keep in mind before you start going through the application process. And keep in mind, this isn't open today. It's planned to be open later in 2026. We'll give you details as soon as that's available. But in order for you to enroll as a correctional facility clinic and to get access into this benefit, you're going to need 3 things. you'll need to have a type 2 or organizational national provider identifier. Doesn't cost anything. It's a very simple process. If your facility doesn't have one already, this can be requested through the organization called the National Plan of Provider Enumeration System, or NPIS. Again, this is a free process. It usually takes a couple of weeks. Anybody can get an NPI. We need facilities to have a type 2 NPI for this process. Second thing you're going to need is a taxonomy number. And that's just again, it's a fancy term for a way that we identify all of our different providers. We have provider types and specialties. This is sort of the national way of how we identify medical providers, or what types of providers a facility or an individual is. We don't have a specific requirement that you have to utilize for a taxonomy number, but we have identified a specific code for prison health that may be appropriate for your facility. So to make this easy, feel free to use that code and take care of that requirement. And then the final requirement is we do need to have a copy of a W-9 form. And we know as a government entity, providers usually will elect to use the county auditor's office for tax purposes. But again, that's up to your discretion. We just need to have an EIN and a W-9 form for whichever organization is claiming taxes. We do want to give a key reminder here that if you're a county jail that already has a contract with FSSA for the presumptive eligibility for inmates process, that's not the same as provider enrollment. So you'll need to go through this separate provider enrollment process in order to receive benefits or receive reimbursement under the benefit that we've described today. Now, when you've got all that together, again, you need your NPI, any other required documentation, make sure you have that W-9. Once you're ready to go, we'll ask you to enroll as a correctional facility clinic through the Indiana Health Coverage Programs. You can do this online through the IHCP Provider Healthcare Portal that we talked about previously. And that's usually the recommended way. It gets you into the system quicker. It allows us to start processing applications a little bit quicker as well. But if you don't have access to the portal or would like to do it through paper, you are able to apply by mail as well. In either route you go, you'll select provider type 08, which is for a clinic. You'll be asked for a provider specialty. You'll click on 089, which is correctional facility clinic. And then you'll also be asked for a provider classification. And we only give you one option in this case because, again, we are enrolling at the facility level, not the individual practitioner level in this case. So we're just enrolling you as a correctional facility, and you'll select billing in that case. You'll also, as a key reminder, even though it's a facility enrollment, we are not requiring an application fee for this enrollment type. Now, you'll go through the enrollment process. Once you're enrolled, your correctional facility will receive a couple things. You'll receive an IHCP assigned provider number, and that's just an internal way for us to track your enrollment and track all of your claims information. But then you'll also receive a welcome kit, a welcome letter, that gives you instructions on how you establish your account with the provider healthcare portal for billing. So you go through the enrollment process, you'll get set up with the portal, and through the portal, you'll be able to submit claims for reimbursement. And again, that's a very quick high-level overview of enrollment, but will be available to help any facility through the process once that becomes available. We do expect it to become available in early to mid 2026, but we'll finalize details as soon as we have that available. But now I think I will throw it over to Maddie Foster from Department of Correction, and she'll give you an update on their activities.
Thanks, Michael. So I'm Maddie Foster. I am the Transitional Healthcare Manager for the Department of Correction, and I oversee the Medicaid processing unit, amongst other things, for the department. I'm sure if you are a criminal justice partner, I'm sure you're wondering how you can kind of prepare for this initiative. I want to tell you, just as a note, not to panic. because as you saw on the implementation phases, this is going to be a pilot initially at DOC facilities, and as we're going to hopefully figure out the gaps and challenges and barriers so that we can pass those key points on to you, and it should be an easier process for you all. So if we could go to the next slide. Okay, so just a few points so everyone is familiar with the things that we have, or the steps we've taken to get to implementation for DOC facilities. If you don't already have a way to look at suspensions and activations or a process there for Medicaid for your folks in in any carceral settings here, you're going to want to kind of identify that. I know some county facilities utilize a contractor that does that work, and I am open to any and all questions if you do have questions about that process or best practices. We're working to update our current process and data share with FSSA to include Medicaid coverage suspensions and activations for our population outlined in this initiative. So that kind of looks like our current process is applicable to adults. We want to, not do this as a totally manual process. We want to kind of automate and expedite for this population and this initiative. As far as clinical systems upgrades go, we need to be able to track services outlined in these regulations for billing purposes, but also we want to be able to track outcomes and see all the good work that we're doing as a result of this initiative. So we're taking a look at our current electronic health record system to identify upgrades and integration for new templates. We have identified materials through a program called Bright Futures. They provide guidelines as a national initiative, and that provides framework and materials for best practices for youth healthcare, as far as screenings, diagnostics, kind of like child visits, if you will, for the justice-involved youth. So we're going to integrate those into our current EMR systems and not kind of reinvent the wheel. As far as identifying screening tools for justice-involved youth, like I mentioned, the Bright Futures guidelines has kind of been identified between ourselves and FSSA as best practices. And like I said, we're not having to reinvent the wheel. They already have a framework for all of the requirements for these regulations. And best practices outlined. So I would encourage you to look into that program as well. And then just outlining general workflows for both internal and external partners. So we have ongoing discussions with other state agencies as a part of this work group, as well as our DOC medical vendor that I recognize a few on this call. So we're all going to have to collaborate on implementation here, and it is vital that you utilize your medical vendor and make them aware of this new initiative so that you can collaborate on implementation for to meet these regulations. And then as well, we're working with our community partners because we know that we need to utilize community partners to address the needs of not only just justice impacted individuals, but especially our juvenile justice impacted folks. So we want to engage with you all to inform policy and procedure as we work towards implementation. And maybe you all will bring to the table, or we hope you will bring to the table, some challenges or barriers that we haven't even thought of yet. And I think I'm going to pass it off after that to Larisha.
Thank you, Larisha Ratliff again, and I'll be going over the limited benefit that is available to the youth 30 days before they are released, and then what's available 30 days after they are released. So next slide, please. So TCM, as I said, is targeted case management, and the billing requirements for TCM is that you would have to complete 2 instances of contact by that targeted case manager is required within 30 days. So they'd have to meet 2 times within 30 days. We are believing that there will be telehealth access available in those requirements. Visit 1, that case manager would need to conduct a social daily living assessment type and review the outcomes of the diagnostic screenings, any of the EPSDT screenings that have already been done, if they've been done already. If not, they need to make sure those screenings are, taking place and happening. Visit 2, recommendation is to provide support for identified needs, post that leaving the facility, referrals, and anything that's going to need to happen in the handoff. So 1 and 2, these visits would be happening in the facility. There'd be 3, 4, right? Once that person is discharged out, but that would be done by a community person. Still, the 2 requirements to build this TCM, you would have to have 2 contacts within a 30-day period, not necessarily the same person, but within that facility who is billing for TCM, there would need to be 2 contacts. We are proposing, not listed here, but the code for the TCM is T2023, I believe, what we're proposing. It is a monthly bundle rate, and I believe the amount is around $184 that we're proposing for that amount. I will clarify that, but I do believe it's T23 and the amount is around $184. Next slide for me. For EPSDT screening and diagnostic services will be available to eligible members through early and periodic screening, diagnostic, and treatment. That is the EPSDT. State-determined screening and diagnostic services must include minimum EPSDT standards, which are spelled out in our provider manual. And then IHCP covered EPSDT services through this benefit will include dental screening and diagnostic services, behavioral health screenings and assessments, health risk assessments, physical exams, laboratory tests, and developmental screenings, vision and hearing screenings. So that is what is included in this limited benefit package that they will have access to 30 days before they're released. And then the 30 days after, they will get the targeted case management as well. Okay, that does complete the actual presentation that we have for you all today. We did receive a couple questions, and so we will move into the question and answer portion of this webinar. The first question that we received is that what organizations are eligible to apply? I believe that is a question that came about confusion. There is no grant that organizations can apply for. The grant was received by FSSA for us to do implementation structure and, like I said, build support for implementation of the services. So there is not a grant that organizations can apply for. The second question, it was, what are expectations for this partnership? And really, the expectations for us is that we do want stakeholder feedback in regards to implementing these services within the facilities, post-discharge or release, what difficulties with providing TCM, providing feedback for us, engaging with us as we move to a statewide implementation of this coverage. We want that feedback because, again, like I said, in 2027, we want to understand the benefits if we apply for an 1115. waiver for any of these incarcerated services or offerings. What would make sense for us to waive? What would be beneficial? What would be helpful? So the expectations are really that you engage with us. If you have feedback, if you have information that will be helpful, complete the survey. But there's no other expectations. The requirements are more on the facilities, and then providing that targeted case management after that individual is released. There's no other expectations for stakeholders and those engaging with us than to provide your feedback and any assistance that you have that will be helpful. We did receive another question, but that question is not really relevant to the webinar today, so we will respond directly to that question. And then we have a couple questions that we have received in the chats to the question and answer, so we'll answer those. So the first question that we received was, can home health agencies enroll as a correctional facility clinic? Michael, I don't know if you answer that here or if we need to take it back.
Oh, sorry. So could you say the question one more time?
Can home health agencies
The home health
enroll
agencies,
as a
yeah.
correctional facility clinic?
No, so this enrollment opportunity is really intended for correctional facilities themselves. So whether that's county jails or any other type of correctional facilities, home health agencies have their own provider type that they would be enrolled as, and they would not utilize this benefit.
Thank you. We did get asked if a copy of the webinar PowerPoint slides will be shared out, and they will. We do have to take them through an internal process for reviewing to post them. And once we get that process complete, we will post the slides, and you can get the slides from the website. Another question was in regards to, can we go ahead and add the MPI and taxonomy number, et cetera, or do we have to wait?
You can definitely pursue that now. I mean, and that's actually a great idea to go ahead and get started. It shouldn't take too long. I think typically they respond within 2 weeks or so, but nothing prevents you from starting it now.
We received another question that says, will payment for the TCM be paid directly to the carceral facility, and then they may not contract with community providers? So the TCM will be paid directly to the carceral facilities while that individual is in the facility. And then once they are discharged, it will be to those that are able to bill the targeted case management outside of the facility. And they may contract with other providers to help and assist with that. But while that individual's in the facility, it should be the facility that is billing that service to us. Who will be providing the targeted case management, and can other agencies apply to render this service? For the targeted case management, like I said, outside of the facility, we've been having conversations with the community mental health centers, looking to work with federally qualified health centers. We are not totally all the way complete with the targeted case management provider side, like in the actual community part. And once we get all of that finalized, then we will provide that information out, and it'll be clear about who can provide the targeted case management. Can agencies that obtain the CHI waiver partner with the county jails? I don't think you can definitely partner with the county jails. I was going to say, I don't think whether you have CHI or not would impact your ability to partner with the county jails. that would definitely be, if that county jail, was seeking partners to help and assist with this, they would do the billing and then they could work with whoever, they would want to work with inside their facilities. We received another question that says, what does the medical director physician at a state juvenile correctional facility have to do besides getting an NOI?
Larisha, I can kind of speak on this. So we are currently working with FSSA to develop not only provider credentialing education, but also policy and procedure on what implementation looks like. So DOC plans to work with FSSA to provide that education, hopefully in the next month.
Okay, thank you for that, Maddie. And it was, instead of NOI, they meant NPI, but I think you answered their question. We answered the TCM questions. And we answered about the facility. I think we answered all the questions that we received during the live part of the webinar as well. And so at this time, we just really want to thank you for spending the morning with us. We are hosting another webinar that will provide the same information. That webinar is December the 9th. I believe it is from 1:30 to 2:30. And so you don't have to join it again if you don't want to. We are presenting the same information. And again, we will post the slides as they are cleared for us to post. We really appreciate your time this morning, and you all have a great and wonderful day.